The treatment landscape for men with advanced prostate cancer is shifting and expanding yet again. As new therapy options continue to emerge, it is important to not only understand what treatment options are now available, but also how they work in fighting the disease. Today, to highlight a few of these new options, we have an award-winning prostate cancer investigator to get you up to speed. So stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. It is indeed an honor to have world-class prostate cancer investigator Dr. Natasha Kyprianou joining us on the podcast today. She has completed fellowships in molecular oncology at Johns Hopkins University and in molecular biology at the Imperial Cancer Research Fund in London, UK. She is a professor in the Department of Urology and Oncological Sciences at Mount Sinai Medical Center in New York City, and a member of the National Cancer Institute designated Tisch Cancer Institute. She has also been active nationally and internationally in several leadership positions, including being a board member of the International Prostate Health Council, member of the American Urologic Association Education Council, and honorary board member of the EAU Council, and has served as president of the Society for Basic Urologic Research. In addition, it is worth noting that she was also the chair of the Department of Defense Congressional Directed Program for Prostate Cancer Research, and was the first female to be elected to this position. Her research focuses on the molecular mechanisms underlying prostate cancer progression to metastasis and apoptosis-driven molecular therapeutics targeting urologic tumors. During her career, she has received numerous awards, including being the first female to be awarded by the American Urologic Association for her contribution to urology research. Dr. Kyprianou, welcome to the Prostate Health Podcast.
Thank you very much. Thank you for having me here, Garrett.
Well, this is definitely a treat, not only for myself, but for our podcast listeners to be sitting here today getting to chat with a world-renowned prostate cancer researcher. Dr. Kyprianou, so what motivated you to follow the path that you've taken to get where you are today?
Well, my journey has been quite interesting. My initial interest in urology and urologic oncology specifically and cancer research was triggered by my postgraduate studies at the University of Leeds in the United Kingdom, where I was studying endocrinology. And I learned a few things about steroid hormones, androgens and estrogens, as well as peptide hormones, LH and FSH. So at the time, my research project was to examine the effect of steroid hormones on human carcinogenesis, looking at metabolic pathways that really drive hormone action in gonadal and urologic tumors, specifically in the prostate gland and the abnormal growth of the prostate. So in a way, I found myself totally seduced, if you will, by this whole concept that such small molecules, such as hormones, can have such a profound impact on the development of sex organs and the differentiation of sex organs during embryonic development, as well as tumor development and growth in adult life. Specifically, the primary incentive to pursue cancer research, and I'm saying that in all truthfulness and honesty, was really my early dream as a teenager. The very challenging nature of cancer as a disease, the multiple causes leading to this huge health problem, and the realization as a young person that people of all ages, including children, of different ethnic backgrounds, social status, race, gender, and education, fight and die daily of this terrible disease. Then I continued my fellowship training at Johns Hopkins under the mentorship of Dr. Don Coffey and Dr. John Isaacs at the Brady Urologic Institute, really the world-class researchers on prostate cancer. So learning from the most brilliant minds in prostate cancer research in the world, I was fortunate But also I quickly became aware that more than 90% of patients with prostate cancer lose their lives to this painful cancer, lose their battle because of metastasis to the bone, pancreas, brain, lungs, and liver. Therefore, that is why I embrace the challenge for my research moving forward. How can we stop those cancer cells from really spreading through the body, through the blood and lymph nodes of these patients to the distal parts of the body, away from their primary site, and develop ways to stop their journey to metastasis and also prevent their colonization and invasion to the distant sites away from the primary site. In a way, how can we kill those cells before they reach their destination of metastasis?
So, and thank you for that. And so the standard primary treatment for advanced prostate cancer has been hormonal therapy. And now for our listeners, when we are talking about advanced prostate cancer, we're talking about the situation where prostate cancer that is no longer confined to the prostate and it's now spread outside of the gland. And now, Dr. Kyprianou, as a quick review, what does it mean for a man to undergo androgen deprivation?
Dr. Pullman, before we go into the treatment options for advanced prostate cancer, please allow me, at least it is important to pause and remind the listeners that more than 30,000 men will die of prostate cancer in 2021. So indeed, prostate cancer is one of the most significant public health concerns in the United States. So while many men are now discovering it and treating their disease at an early stage while it's still locally confined with excellent survival outcomes, the survival rates really drop dramatically once the cancer has metastasized to distant sites. So for these patients with tumor recurrence and the development of metastatic disease, androgen deprivation therapy, or ADT, as you mentioned, is a primary standard of care and works by either decreasing the androgen levels via blocking the production of the hormone centrally, or by inhibiting the binding of androgens such as testosterone and DHT to their receptors peripherally. So ADT targets the androgen receptor pathway, the signaling network that is really elicited in response to androgens, that is essential to the growth and function of the prostate gland and ultimately the prostate tumors. ADT, since its original discovery by Dr. Johns Hopkins in the 1940s, can be achieved surgically via orchiectomy, or more recently can be really applied by using androgen receptor inhibitors pharmacologically via the chronic administration of either LHRH agonists such as Lupron, or AR inhibitors, androgen receptor inhibitors such as baculotamide or flutamide. Although many patients will initially respond to this treatment, to ADT, most patients will eventually develop castration-resistant prostate cancer, as it's called, and ultimately metastatic lethal disease that claims the life of these patients. So, and it does so despite the fact that after ADT, some patients are able to reach castrate levels of androgens. So where do these androgens come from after ADT? It is critical to understand that the signaling drivers and the underlying mechanisms of the emergence of prostate cancer therapeutic resistance after ADT can be amenable to pharmacologic inhibition. And that's where the scientific discovery comes in, trying to understand these mechanisms of resistance and overcome them.
Well, that's certainly a wonderful overview of ADT or androgen deprivation therapy, but also, you know, we kind of started getting into that resistance that prostate cancer can get to this therapy. And so in recent years, novel agents have been developed for the treatment of advanced prostate cancer, such as abiraterone and enzalutamide. While nobody desires to have advanced prostate cancer, it is definitely exciting to see that there are even more treatment options available now to men with the disease. Would you agree?
Absolutely. I agree totally. And the development of second-generation anti-androgens such as abiraterone and enzalutamide, provided that have been approved by the FDA almost 10 years ago for the treatment of metastatic castration-resistant prostate cancer, has really advanced the field and provided a lot of promise to patients with prostate cancer. I would like to remind the audience, though, and ourselves all the time, that prostate cancer is a remarkably heterogeneous solid tumor and is driven by diverse factors. The one thing that we've known for many, many years now, and where research is leading us, is that the primary driver of this development, even of this therapeutically resistant prostate cancer, is the androgen receptor. even again in recurrent tumors after ADT. So the androgen receptor, which is a molecule that is fundamental to the action of androgens within the prostate tumors, is really the protagonist, if you will, that people around the globe have been focusing their research efforts to try to understand how it can be overcome in order to overcome this therapeutic resistance. So, and again, I would like to go back to the ADT, that although ADT has the primary effect of reducing androgen levels to castration levels, to very low levels of testosterone and DHT, patients with castration-resistant prostate cancer have persistently elevated levels of androgens that may be derived from production of DHT within the tumor or from the adrenal glands, that we'll see later on why that provides a target for the use of abiraterone. But I just want to just summarize about the action of these anti-androgens, that we must consider that the androgen receptor-directed mechanisms span multiple levels of the androgen axis and affect the synthesis, the utilization, and the signaling of androgens. So, and consequently, to recognize that these mechanisms, these very cellular events, are clinically relevant for therapeutic targeting. And these are the same mechanisms that are targeted by the second-generation anti-androgens that provided such clinical promise, enzalutamide, Xtandi, and abiraterone or Zytiga.
And I thought it would be very helpful for our listeners to even further hone in today and learn more about these two new novel medications. And I thought we could first kind of dive in and focus on the medication enzalutamide, also known as Xtandi. Again, so how does this drug work in helping men with advanced prostate cancer?
Enzalutamide is a very interesting molecule. It was developed and has been approved. And the way enzalutamide is acting is really by binding or competing for binding to the ligand binding domain of the androgen receptor. And what we mean by the ligand binding domain is the area, the sequence on the androgen receptor molecule, the gene, that the ligand, in this case the DHT or testosterone, are able to bind. And if enzalutamide does that competitively, it's able to block the formation of the active complex androgen receptor. It is a formation and the internalization of this complex of the androgen with the AR, bound to the AR, that gets translocated into the nucleus of the prostate cell, or the prostate tumor cell, and therefore is able to elicit the activation of the androgen receptor gene, as well as the growth response to androgens, promoting the growth of the tumor. So if enzalutamide is able to compete, so instead of the androgen, we have enzalutamide binding to the AR, the complex can no longer be viable, can no longer be translocated into the nucleus, and therefore there is no really activation of any specific gene expression in response to androgens, and therefore we have regression of the tumor. And that's how, in a very, I guess, overall summary, that's how enzalutamide is acting. Clearly it's affecting some other molecular events, but this is the primary inhibition of the androgen receptor action by enzalutamide. It's translocation, it's localization from the cytoplasm of the cell into the nucleus.
Well, very fascinating. I mean, from a research perspective, how is a treatment like this even discovered and then ultimately brought to the point where it's available to the consumer?
Oh, yes. There have been a series of preclinical trials that really led to the preclinical evidence as well as molecular studies that identified enzalutamide to have such a strong inhibitory action against prostate growth in cells in vitro as well as in clinical models, and later on, of course, in the clinical trials. In terms of the clinical significance of enzalutamide, there have been several clinical trials that established the efficacy, of this drug in patients with non-metastatic castration-resistant prostate cancer, with metastatic castration-sensitive prostate cancer or hormone-sensitive, that is also, equally aggressive advanced disease, but also in men with metastatic castration-resistant prostate cancer after failing to ADT. What I would like to say here, though, is also that enzalutamide alone maybe cannot always, what we learn from the clinical trials and some of the preclinical work, cannot really be optimized. Maybe we can be considered in combination with chemotherapy, especially first-line chemotherapy such as docetaxel. So to that effect, several clinical trials have shown that enzalutamide improved the overall survival as well as the radiographic progression-free survival in patients with metastatic castration-resistant prostate cancer who had received taxane chemotherapy, such as docetaxel, as well as in those who are chemotherapy naive. However, the increase in the patient survival is only modest, a few months. to say the least, when enzalutamide is given alone. The biological mechanisms underlying this resistance to enzalutamide include changes in terms of the production of androgens within the tumors, the overexpression of the AR, as well as mutations in the gene for the androgen receptor, and the more recent discovery, of course, of the permanently activated AR variants, splice variants. So I would say that enzalutamide may be, in order to optimize the impact, the therapeutic impact of this drug in advanced high-risk castration-resistant prostate cancer, is perhaps contemplating giving in combination with taxane chemotherapy in order to really have optimal therapeutic response in these patients with advanced disease.
Well, excellent review there. And again, for our listeners, we covered kind of really the three kind of groups of patients that are candidates for this, including both those with metastatic castrate-sensitive prostate cancer, as well as those that have resistance to the castration, but also in the metastatic realm, but also in the non-metastatic where there's resistance to that therapy. So really multiple options there where this treatment can come into play. So what about some of the common reported side effects from this medication?
In terms of enzalutamide, the most common side effects is hypertension, hot flashes, and also elevation of blood sugar. But the most important one is really hypertension. So, and of course, hot flashes because we're dealing with an anti-androgen. And that's why maybe combination in terms of lowering with the dose and combination with other drugs or the administration can maybe minimize also the side effects, because that's also the goal, to really improve the quality of life or maintain rather the quality of life of these patients.
So now lastly, looking at another novel agent, abiraterone or Zytiga, how does this drug work in helping men with advanced prostate cancer?
Yes, abiraterone, also considered a second-generation anti-androgen, is really targeting a totally different biological scenario than enzalutamide. So I just want the listeners to really contemplate that prostate cancer cells are also able to convert some weaker androgens that are produced by the adrenal glands, such as androstenedione or dihydroepiandrosterone or DHEA, into testosterone and 5-alpha dihydrotestosterone, the active androgens that are able to bind to the androgen receptor, and because they have a much higher affinity for the AR. So we cannot really underestimate the contribution of the adrenal glands to this androgen pool, if you will. And it's important to mention that the scientific evidence over the years has revealed that even low levels of androgens are enough to significantly amplify the androgen receptor response in vivo, and then the amplified AR, the androgen receptor, can in turn efficiently utilize and enhance the signal, ultimately leading to enhanced growth of the tumor. Now, going back to the production of these, weaker androgens by the adrenal glands, what the abiraterone does, it specifically targets the biosynthesis of testosterone by inhibiting the enzyme known as C17 that is found primarily in the adrenal glands and also the testes. So the treatment with abiraterone has to be combined with prednisone and has been shown to have really significant clinical and therapeutic benefit in terms of overall survival in patients who are chemotherapy-naive men who have advanced metastatic castration-resistant prostate cancer. So over the placebo and prednisone alone. And also more recently, the Latitude trial in which patients with newly diagnosed high-risk castration-resistant prostate cancer given abiraterone and prednisone, as well as maintaining the traditional ADT, had an improved survival, overall survival, as well as progression-free survival compared to ADT alone. Now, the question that I'm sure many of the patients wanted to know when it's often asked, why is prednisone given with abiraterone? So prednisone is really given for the purpose to actually reduce the side effects from this anti-androgen treatment, because abiraterone, as we discussed earlier, is really targeting the production of cortisol, where it's targeting the adrenal glands, but we know the adrenal glands is a major source of cortisol production. And what Zytiga does, what abiraterone does, is to effectively and significantly lower blood levels of cortisol in many of these prostate cancer patients taking the drug for their castration-resistant prostate cancer. So the prednisone is considered as a cortisol replacement therapy, which can help reduce the side effects arising from the treatment with abiraterone. In terms of the common side effects, for this medication are fatigue, joint pain, high blood pressure again, the same as thalidomide, hot flashes, nausea, as well as diarrhea and high blood sugar levels. And that's why it's so important to minimize some of the side effects by replacement with cortisone, specifically with high blood pressure.
Well, certainly an excellent review there of that second novel agent, Zytiga. Now, one of the more common questions I have to address when prescribing these novel therapies is, from the patient, now that my prostate cancer is resistant to the standard hormonal therapy, such as the Lupron or the shots, the ADT shots, do I need to keep getting these injections with the start of the new therapy? How would you respond to that question?
Well, I have to give a very thoughtful answer to this, or respond rather. First, I would say the current guidelines recommend to continue ADT as a standard hormone therapy in these patients, despite the fact they're given these novel anti-androgen therapies. However, I must say, in all honesty, that objective contemporary evidence for this recommendation is lacking. So the nearest data that point to support that it is worthwhile for these patients to continue on ADT is from clinical trials in patients with hormone-sensitive prostate cancer. So in this hormone-sensitive setting, only of the disease, of the clinical disease, enzalutamide plus ADT or abiraterone plus ADT improved progression-free survival. In the case of castration-resistant prostate cancer, the clinical evidence is not out there yet. And why this is important to really discuss and consider that in more depth is that the very mechanisms of resistance to both drugs invariably develops, as we know. And this is attributed to various mechanisms. So in addition of the layering the ADT, then we have maybe mutations in the ligand binding domain of the androgen receptor, and therefore this is able to induce a switch from the enzalutamide from being an antagonist to an agonist. It can actually promote the androgen receptor translocation to the nucleus and can elicit different effects. So this is in the absence of androgens, or in the absence of, or the presence of very low level ADT levels of androgens. So therefore, by keep pounding it with further ADT, it really will not have any clinical or biological benefit. As I say, the evidence is not out there yet. So, and also, since abiraterone, another issue that in terms of mechanism of resistance to abiraterone, since abiraterone is often given, as we just discussed earlier, with prednisone to minimize the side effects of the anti-androgen, and there is one of the mutations that has been identified in the androgen receptor actually allows the stimulation of AR by glucocorticoids, such as prednisone. So by giving abiraterone as well as prednisone in a subset of patients who harbor this mutation, then you can actually promote resistance to abiraterone via an enhanced sensitivity to prednisone. So there is all this promiscuity among the steroids that one has to consider, and that really speaks to the need for the development of personalized therapies, for the development of personalized screening in terms of this at the molecular level, to really establish and identify the presence of these various exotic mutants or mutations in the structure of the androgen receptor. That was the reason I had mentioned earlier, that the androgen receptor maintains its role as a protagonist for targeting even in patients with castration-resistant disease. We also need to mention here the splice variants for the androgen receptors that have been shown to be implicated in therapeutic resistance to both abiraterone and enzalutamide, especially the AARV7, and that is really capable of totally ligand-independent activation of the androgen receptor. It doesn't need anything. Just the AR variant can translocate to the nucleus. It doesn't need to bind to any testosterone or any androgens or cortisone, but it is also found in abundance in castration-resistant prostate cancer. And for that discovery, we need to give credit to the landmark study that came from Johns Hopkins a few years ago that really established for the first time that the androgen receptor V7 variant is circulating tumor cells from patients with castration-resistant prostate cancer is associated with this resistance to anti-androgens.
Definitely an excellent overview, and definitely a lot to keep in mind there. And so Dr. Kyprianou, you continue to remain on the cutting edge of prostate cancer research. The last 10 years has certainly been exciting with continued new treatment options emerging for men with advanced prostate cancer. What would you say does the future hold for advanced prostate cancer in the next 10 years?
Well, we are very excited, of course, that to witness that evidence of the genomic and molecular mechanisms of prostate cancer, this is done globally by investigators around the globe, has really paved the way for personalized treatments and also the development of reliable biomarkers or biomarker signatures with high diagnostic value. But also we need to remind ourselves that this emergence of castration resistance in patients with prostate cancer has reinforced its major needs, it's a huge need for understanding of actionable drivers of prostate cancer progression beyond the AR. We talked about how important the AR, but now is even in advanced castration-resistant disease. But the way we look forward to the next 10 years of discovery and implementation of those discoveries in the clinic is that we need to think beyond the AR. So if I may, I would like to go back to chemotherapy using taxane chemotherapy because prostate tumors, as we all know, are very slow proliferating tumors compared to other solid tumors. So the only chemotherapeutic modalities available is really taxane chemotherapy that have been approved by the FDA and for the last several years have been used either alone or in combination with anti-androgens in patients with castration-resistant disease. Chemotherapy, I understand, is considered a bad word, especially for prostate tumors, okay? Patients rather hear more about hormonal therapy than chemotherapy because it's nasty, it has tremendous side effects, cannot be tolerated well by a number of patients. However, the clinical, as in terms of these medications that have been approved by the FDA, the taxanes really can be used to treat advanced metastatic resistant prostate cancer. Maybe there is preclinical evidence, or no, maybe I know there is preclinical evidence that is coming from preclinical models that the combination and the sequencing of taxane chemotherapy with these second generation anti-androgens can really provide tremendous therapeutic promise in terms of minimizing the side effects and minimizing the dosing by both agents, the taxanes and the anti-androgens, in order to effectively eradicate these advanced tumors. And the reason I'm saying that is because some work from my group, as well as confirmed by other individuals, by other scientists, that taxanes can really control the activation of the androgen receptor, something that was not known several years ago. So now we're talking about these two totally different medications coming together and together targeting the androgen receptor action. In terms of moving forward, I would like to say that, of course, I'm a basic scientist, I'm a researcher. We must let the mechanism-based really scientific knowledge to lead the way and to be translated to the clinical decision-making in order to facilitate the urologists and the medical oncologists to make the appropriate decision for the patients with advanced disease. Going back to my early challenge that I put to myself, that really targeting these metastatic prostate cancer cells, we have to find really ways of understanding the mechanisms that really drive the cell killing of these, or the mechanisms of cell death or program apoptosis, which is a genetic phenomenon that can be controlled from within the cells. However, during the development of tumors, especially in metastatic tumors, there is loss of this cell killing control within the cell. So we have to develop some novel drugs or maybe manipulate the combination of agents in order to overcome this resistance to cell killing during cancer progression to metastatic disease. Or in another way of putting it is really we have to find ways of exploiting these mechanisms, understanding the resistance in order to reinstate the tumor cell killing ability of the tumor cells in response to therapeutic modalities in those patients who have developed resistance to the current therapeutic modalities. So for prostate cancer specifically, we have different programs. Specifically, we have a dynamic drug optimization program that actually is supported by the NIH, supported by PCF, that not only for new drugs, but also the drug repurposing that I'm sure you hear very often. There is a series of drugs that have been approved by the FDA for other purposes that can be repurposed for the treatment of prostate cancer. And this really provides a path for quickly accelerating some of these drugs to implement them in order to treat patients with advanced prostate cancer, in order to totally, cure the disease. Now, and we built on this knowledge. I'm not going into specific drugs. Some of the drugs are out there. They're diabetic drugs, metformin, alpha blockers. But as we built on this knowledge of repurposing some of the existing drugs that have been approved by the FDA, but also we have the molecular knowledge that we gain as we dissect these pathways of apoptosis or cell death, we can really pursue the identification of some novel gene signatures that will help us to classify at the molecular level which of those cancers are going to progress to metastasis, to advanced disease, to lethal disease, versus those that are going to have only indolent disease. So these markers will really also facilitate the prediction of the different treatment modalities the clinicians can offer to the patients, and maybe combination of them, implementation of the new modalities from drug repurposing or from the new agents with existing therapeutic strategies. And one cannot really underestimate, I know the word biomarker is a very loaded term because not only we need to discover biomarkers, but also we need to validate them. Biomarkers will really enable the detection of early stage, the onset of metastasis, as I mentioned a minute ago, that can be impaired effectively for pharmacologic intervention, and in addition to predict the therapeutic failure in this subset of patients with advanced disease, however, who failed given the standard hormonal treatment, ADT, or even chemotherapy and anti-androgen. So what we really can hope is really improve the patient survival as well as the quality of life. What can we do the next 10 years, or what do the next decade promises how to manage prostate cancer patients? Well, novel immunotherapies, radioactive agents, small molecule inhibitors that are specifically targeting the specific signaling pathways of prostate cancer cells that enable their survival, they're enabled to overcome, their death. And of course, more recently, provided by the FDA, the PARP inhibitors, specifically olaparib, that was approved by the FDA last June for the treatment of patients with metastatic castration-resistant prostate cancer. This drug, was used for the treatment of BRCA-driven ovarian cancer. So it was very exciting for the prostate cancer field and for the patients to see that now we have a drug that can really target, metastatic castration-resistant prostate cancer in an effective way. But this is, however, only for the patients who have prostate tumors with harboring specific alterations in these genes that are involved in homologous recombination repair. So PARP is a molecule that is involved, it's a polymerase that is involved in DNA replication. So by targeting that, one is enabled to really stop the replication of the DNA and ultimately the tumor cell growth. Lastly, in addition to, as the new decade unfolds, the task before us as scientists and clinician scientists alike, as well as clinicians, is to utilize liquid biopsies. That this is really something but very exciting, very exotic, that has emerged from recent studies that is really looking at liquid biopsies at these exosomal molecules that are secreted by prostate cancer cells in the circulation, that one is able to really, assign diagnostic value without, it is a minimally invasive procedure. It doesn't involve a biopsy. So we hopefully believe that eventually these liquid biopsies can replace the often painful and risky tissue biopsy. And also along those lines, I would like to emphasize that this approach will enable and will empower us, as a multidisciplinary team to develop these personalized therapies for castration-resistant prostate cancer in order to maximize therapeutic response and ultimately minimizing toxicity of the various combination strategies in these patients.
Well, thank you for that. And certainly exciting times as urologists and oncologists continue to have more tools available in our tool bag to fight the disease, but also start utilizing more personalized treatment to target our treatment strategies. So Dr. Kyprianou, any final thoughts today for our listeners?
Yes, thank you, Garrett, for the opportunity. And also I would like to share a message of hope and promise regarding the treatment and management of prostate cancer moving ahead. There are unlimited possibilities that are really unfolding for eradicating advanced prostate cancer and also eradicating the suffering, not only death, but also suffering of these patients with prostate cancer. So my optimism stems from the following. First, going back to team science approach, this team science-based discovery built on multidisciplinary team expertise can lead us to develop clinically and identify molecular signatures for patients with advanced metastatic tumors towards a new understanding of their mechanism that is really the mechanisms underlying their specific resistance process. Okay, why are this group of tumors really, what is the biology that is driving the resistance to the current treatments, including the anti-androgens that we talked about earlier and taxane chemotherapy? And maybe understanding that can give us the opportunity to develop and apply some of the novel treatments, such as immunotherapy, checkpoint inhibitors, DNA repair inhibitors. Secondly, I would like to emphasize that application of personalized approaches really will define a new platform for providing personalized treatment, understanding the individual biology of each tumor. Cancer is a heterogeneous disease within a tumor, prostate cancer that is, but also maybe it's about time moving forward with the technology that's available to us. And I understand this is not cost-effective, but eventually it might become cost-effective. So defining by proteomic analysis the complex signaling pathways and the complex survival pathways existing at the cell level for each tumor that can be different from the next patient. So these are networks that are they're multi-layered, and it's up to us to use the technology to derive some of the clinically actionable targets within these pathways. And what do we mean by actionable targets? Again, it's a term that is often used now, and it's a very attractive term. But what we mean is to define those molecules, not only the events, but the molecules that are really responsible. Again, we're moving beyond the AR. That these are molecules that have been there all along and maybe characterize each individual tumor to a certain degree, to a different level than another tumor. So these actionable targets, understanding of them and really dissecting them and defining their function in the promotion of prostate tumor to metastasis will empower the new platforms for therapeutic targeting tailored for each patient. Again, thinking about advancing personalized therapy. I would like to end, though, as well, in addition to the approach that is there, we must also invest in human capital. I must emphasize, as a mentor and as a researcher, that the dynamic exchange, really the flow of ideas between scientists, between clinicians, between urologists, radiation oncologists, medical oncologists, really this is the building of this expertise among multidisciplinary collaborations, not only within a single institution, but with multiple institutions, is a path moving forward. Before we reach to that clinical trial, before we take in those drugs or these combination strategies, we need to have the appropriate personnel, the basic scientists trained in the lab, the young scientists that are really qualified to conduct first-class prostate cancer research in order to and taking advantage to really of their talent and their creativity to apply and utilize the technology that's available. And the technology that is available for drug screening, for tumor staging, as I said, minimally invasive biopsies, liquid biopsies, the genomic profiling, separating tumor cells at the single cell level. Now we have these advantages. This is the 21st century. So this is where the new decade is taking us. And the single cell level analysis, also the protein analysis, these are the protein interactions that you remember are able to facilitate the interaction between the steroid hormone and the androgen receptor. Maybe there are other proteins that are there that we have been ignoring because we didn't know about them. So really dissecting that at the single cell level in prostate tumors in individual patients can lead us to more personalized approaches really for detecting and maybe preventing progression to metastasis. So on a daily basis, our charge with our team is really to work very hard with passion to translate the scientific findings from the lab to the clinic. And the goal is to save lives of men with prostate cancer, especially those men with lethal disease.
Well, thank you. Thank you again today for chatting with us here on the Prostate Health Podcast. Solid gold information. You definitely provided our listeners with significant value today. We really appreciate you taking time out of your busy schedule.
Thank you very much. It's really been delighted to be here, and thank you for the opportunity to share my thoughts with your listeners. Thanks, Garrett.
Yep. Thank you. Thank you again for listening to the Prostate Health Podcast. Follow me on Twitter and Instagram at gpullmanmd. Don't forget to join us next week for another episode.